Welcome to the Week in Diabetes and Endocrinology from Hormone Insight. This podcast delivers a summary and perspective on the top news of the week that endocrinologists, diabetologists, and internists can't afford to miss. This podcast is intended for healthcare professionals. For the week ending May 1st, 2026, I want to talk about the FDA's clearance of an automated insulin delivery system for use during pregnancy in type 1 diabetes. A genuine first, a U.S. cost-effectiveness analysis of tirzepatide versus semaglutide in type 2 diabetes with concrete ICER numbers. The late-breaking signals coming out of AACE in Las Vegas. A fresh meta-analysis showing dapagliflozin meaningfully improves hemoglobin in chronic kidney disease. The state of hypoglycemia, risk prediction models in type 2 diabetes, and why most of them aren't ready for your clinic. And a small, but mechanistically clean trial showing that a short, calorie-restricted oat diet moves zonulin and short-chain fatty acids in metabolic syndrome. Let's get into it. First story, and in my view, the most clinically meaningful regulatory news of the week. On April 27th, the FDA cleared Tandem Diabetes Care's Control-IQ Plus automated insulin delivery system, AID for short, for use during pregnancy in women with type 1 diabetes. According to Tandem, this is the first commercially available AID system cleared for pregnancy use in the United States. Why does this matter? Because pregnancy in type 1 diabetes is one of the highest stakes glycemic environments in all of medicine. The pregnancy-specific glucose target, 63 to 140 milligrams per deciliter, is tighter than what we use outside pregnancy. The fetal consequences of poor glycemic control are well known: macrosomia, neonatal hypoglycemia, congenital anomalies, preterm delivery, preeclampsia. And the mother is doing all of this while insulin requirements double or triple, then crash postpartum. It is brutal physiology, and it is exactly the kind of problem closed-loop systems were built to solve. The clearance is supported by the Circuit trial. Multi-center randomized controlled trial, pregnant women with type 1 diabetes, randomized to Control-IQ Plus versus standard pump therapy from 16 weeks gestation until delivery. The headline result that Tandem cites, a 12.6% absolute improvement in pregnancy-specific time in range, that's the 63 to 140 band, which translates to approximately 3 additional hours per day in target. That is enormous in a pregnant patient. Now, I want to be honest about what we know and don't know. Circuit was a real but modest trial. It was not powered for hard maternal fetal outcomes, large for gestational age, neonatal hypoglycemia, perinatal mortality. So the formal evidence base says AID in pregnancy improves time in range. The leap from that to fewer adverse perinatal outcomes is biologically plausible and supported by observational data, but not formally proven by this trial alone. That said, this is the right direction, and I think this clearance will rapidly become the standard of care for pregnant women with type 1 diabetes who can access pump therapy. Tandem has announced training events for clinicians at the ADA 2026 scientific sessions in New Orleans this June. If you manage pregnant type 1 patients, plan to be there. The unresolved questions are about real-world implementation. Most OB Oats endocrine teams managing pregnant type 1 patients are not currently fluent in AID systems. There's a learning curve for the patient, a learning curve for the team, and a workflow to figure out for the on-call provider at 3 in the morning. We have the tool. The infrastructure has to catch up. Bottom line, FDA cleared closed-loop insulin delivery in type 1 pregnancy is a real advance. Use it, but do not assume that handing a pregnant patient a Control-IQ Plus pump replaces high-touch maternal fetal medicine and endocrine co-management. It does not. Second story. Let me reframe this one carefully because I want to be precise about what was actually studied. A U.S. cost-effectiveness analysis published this month asks whether tirzepatide is good value for money compared to semaglutide in adults with type 2 diabetes. Important, this is a type 2 diabetes analysis, not an obesity-only analysis. The model uses data from the SURPASS clinical development program rather than the SURMOUNT obesity trials. The results are interesting and concrete. Tirzepatide 10 milligrams produced an incremental cost-effectiveness ratio of approximately $70,147 per quality-adjusted life year gained compared to semaglutide 2 milligrams, Tirzepatide 15 milligrams produced an ICER of approximately $54,699 per QALY. Both numbers are below the commonly used U.S. willingness to pay threshold of $100,000 to $150,000 per QALY, meaning both tirzepatide doses were modeled as cost-effective versus semaglutide 2 milligrams over a long-term horizon. Now, the standard caveats apply, and they're important. First, this is a model. Long-term outcomes are extrapolated from short-term trial data plus epidemiologic projections of cardiovascular and renal complications. Model assumptions about long-term cardiovascular risk reduction from greater weight loss and better glycemic control are reasonable but not yet fully proven for tirzepatide at the population level. Second, the US retail pricing landscape is in flux right now. Direct-to-consumer cash pay channels, the new CMS balance model for Medicare obesity coverage, and the looming generic landscape will all move the cost-effectiveness curves over the next 2 years. Third, a separate question, whether tirzepatide is similarly cost-effective for obesity without diabetes, is not what this paper addresses. Don't extrapolate. What does this mean clinically? If your patient has type 2 diabetes and you can choose between tirzepatide and semaglutide on therapeutic grounds, the modeled long-term value favors tirzepatide. In real-world practice, access, meaning insurance coverage, supply, patient tolerance, usually drives the choice more than ICER math. But it's useful to know the economic data point in the same direction as the head-to-head efficacy data. Third story. The AACE annual meeting wrapped up on April 24th in Las Vegas. Late-breaking abstracts are publishing in the Endocrine Practice Supplement now. Let me flag a few signals worth tracking as those papers fully publish. I'm going to keep this general. Specific abstract numbers and pooled estimates need to be checked against the supplement before anyone quotes them on air or in clinic. On obesity pharmacotherapy, the orforglipron Attain-1 body mass index subgroup analysis we covered last week was the headline. The takeaway is consistent weight loss across the BMI spectrum with the predictable modest gradient favoring lower BMI patients. Wait for the formal publication before you cite specific subgroup percentages. On thyroid, the post-microcystic reflection ultrasound finding in indeterminate nodules, Bethesda 3 and 4, is a small but provocative signal that needs replication before it changes practice. Keep an eye on the full publication. On socioeconomic determinants of obesity care, several presentations quantified what most of us have observed clinically, that lower income and education affect treatment access, retention, and outcomes, and push toward more structured counseling frameworks. This belongs in your practice as a structured assessment, not a passing observation. The broader signal from the meeting that I want to highlight. Combination therapies are dominant in the obesity pipeline. CagriSema, retatrutide, survodutide, the Boehringer triple agonist. The 2027 and 2028 obesity therapeutic landscape is going to look very different from 2025. As clinicians, we should be reading the phase 3 data critically as it lands, and not overcommitting patients to a single agent when the toolkit is rapidly expanding. Bottom line on AACE 2026, a signal-rich meeting with the obesity, thyroid, and bone tracks especially noteworthy. Don't try to read the full supplement in one sitting. Pick the abstracts most relevant to your practice and read them carefully when full papers come out. Fourth story. A new systematic review and meta-analysis published April 23rd in Renal Failure addresses something that has been creeping up in the SGLT2 literature, whether these drugs actually improve anemia in chronic kidney disease. The biological premise is intriguing. SGLT2 inhibitors, dapagliflozin in particular, appear to stabilize hypoxia-inducible factor in the renal cortical interstitium, which drives endogenous erythropoietin production. In animal models and small observational human studies, this has translated into measurable hemoglobin increases. The question for this meta-analysis is whether that effect is real, reproducible, and clinically meaningful. The pooled, randomized controlled trial data show that dapagliflozin produces a statistically significant increase in hemoglobin compared to control. The mean difference was 4.37 with a 95% confidence interval from 0.71 to 8.03, p-value 0.02. Sensitivity analyses also showed a hematocrit signal in the same direction. Translated into clinic room terms, This is not a marginal blip. Several grams per liter of hemoglobin improvement is a real measurable change, particularly in chronic kidney disease, where the baseline hemoglobin is often hovering near anemia thresholds. The mechanism, HIF-driven erythropoietin, is biologically distinct from anything else in our metabolic toolkit. Now, what does this actually change in practice? Anemia in chronic kidney disease is common, often undertreated, and contributes to fatigue, reduced quality of life, and cardiovascular risk. The standard pathway is iron repletion plus erythropoiesis stimulating agents in selected patients, both of which carry their own cost, complexity, and adverse event profile. If SGLT2 inhibitors deliver a meaningful hemoglobin signal on top of their established cardiorenal benefits, that is a useful bonus mechanism, particularly for the very common patient with type 2 diabetes, CKD, anemia, and heart failure all together. You're already prescribing dapagliflozin for the kidneys and the heart. You may be improving the anemia for free. The bottom line, don't reach for an erythropoiesis stimulating agent solely on the basis of this meta-analysis. But if your CKD patient with mild anemia is not yet on an SGLT2 inhibitor and they have an indication, dapagliflozin is the right agent to start, and you should expect a measurable hemoglobin improvement as a bonus. Fifth story. Let me use this slot to talk about something broader. The state of hypoglycemia risk prediction in type 2 diabetes and why most of the published prediction models out there are not yet ready for your clinic. This matters because hypoglycemia in older insulin-treated type 2 diabetes is one of the most modifiable causes of hospital admission, falls, cognitive decline, and mortality in our practices. We have known for years that risk-stratified de-intensification works. What we have not had is a robust, validated, clinically deployable risk prediction tool that integrates with the electronic health record and tells us in real time who needs de-intensification. The pattern in the published literature, and this is well documented, is that most prediction models perform reasonably in the development cohort. Fewer externally validate, and very few have been deployed in actual clinical workflows. Almost none have shown improved patient outcomes in a prospective cluster randomized trial. That's the honest state of clinical machine learning in metabolism today. Lots of papers, decent AUCs in development cohorts, very limited prospective deployment data, and almost no outcome trials. Until we have prospective deployment with documented patient benefit, these models are interesting research, not standard of care. Treat them with skepticism when vendors come selling them to your health system. What you can do right now is more practical. For your insulin-treated type 2 patients over 75, with CKD, with cognitive decline, or with a history of severe hypoglycemia, proactively de-intensify. Lower the A1C target. Drop the sulfonylurea. Reduce basal insulin. The prediction model you need most is your clinical judgment plus a continuous glucose monitor. If AI prediction tools eventually augment that, great. We are not there yet. And last story, rapid fire with a clinical pearl. Published April 23rd in Gut Microbes, a randomized controlled trial in adults with metabolic syndrome that asked a focused question. Does a calorie-restricted, oat-enriched diet measurably affect intestinal barrier function and microbial metabolites? The trial had 2 arms with 2 different durations, and the distinction matters. A short 2-day, calorie-restricted high-dose oat diet was compared to a standard control, and a separate 6-week isocaloric oat diet was tracked over time. Here is what the trial showed. The 2-day calorie-restricted high-dose oat diet significantly lowered serum zonulin, a marker of intestinal permeability, and increased plasma butyric acid, one of the key short-chain fatty acids produced by gut microbes from soluble fiber fermentation. The 6-week isocaloric oat diet showed stable parameters, meaning the acute calorie-restricted high-dose oat exposure is what moved the biology, not chronic isocaloric oats. Why does this matter? Because for years we have been saying diet quality matters, not just calories, and the evidence underneath that statement has been mechanistic and inconsistent. This trial gives a more precise framing. The food matrix and the dose and duration of exposure all matter. A short, intense oat-focused dietary intervention with a calorie deficit moves measurable biology, gut barrier function, and microbial metabolite output. A chronic, calorie-neutral version of the same dietary pattern doesn't show the same acute signal. Practical translation. When you counsel a patient with metabolic syndrome on dietary change, the short-term, focused, calorie-restricted intervention may move biological markers more than chronic dietary tweaking. Soluble fiber, beta-glucan from oats, fermentable substrates that feed beneficial gut microbes are not health fad framing. They are mechanistically active components of the diet. Small trial, single context. Don't generalize to all populations, but it adds modestly to the practical advice you're already giving and gives a slightly stronger mechanistic story to tell. That's your week in diabetes and endocrinology from Hormone Insight. If you found this useful, share it with a colleague. And if you disagree with anything I've said, I hope you do, because that's how we get better. You can find show notes with all the references at hormoneinsight.com. Until next Thursday, keep questioning the evidence, keep learning, and keep putting your patients first. Thank you for listening.